you so much for the invitation to present the tips and tricks for mitral transcatheter edge-to-edge repair, anatomy and imaging. My name is Julie Grapsa and I'm based at Brigham and Women's Hospital in Boston. So thank you so much, Dr. Iakovou and all the faculty at Onassis Cardiothoracic Hospital for the kind invitation in beautiful Athens. So starting from the guidance for transcatheter interventions and mitral clip, we should look at the echo as pre-procedural, intra-procedural, and post-procedural. And practically, we need to do a full assessment for scallops and commissures and Carpentier classification, clefts and indentation, and mitral annular disjunction. Practically, we need also to look the chambers and then to do the appropriate Doppler measurements. So always never forget to do a full protocol. When it comes to the anatomy of the mitral valve, we know that we have the 6 different scallops from the anterior and posterior leaflet, and the anterolateral commissure and posteromedial commissure, and also don't forget the mitral annular shape that is like a saddle shape, which is very different from the tricuspid annulus. So use all your senses to visualize the mitral valve. So we're always interested in the relationship with the aortic valve, whether there are any clefts or indentations, whether there is or not any calcification and the extent of that, and of course, if there are any anatomical changes across time. So starting from the basics, when we do the TE, first we'll get the mid-esophageal view that we usually see the A2P2, and it's important to get the measurements for the LV and also left atrium, and it's a first image and to assess what's the etiology of the mitral regurgitation. Then moving to the mitral commissural view, which is very important, 60 degrees, we usually see the P1, A2 and A3, and then also very important the 90 degrees that we see the extent of the anterior leaflet and P3, and then the one important view for 3D is the P2, A2 side on the 120 degrees. So you see an overall assessment of the mitral valve. But very important for transcatheter and structural is the 3D reconstruction that we see all the scallops. As you can see here, we move aortic valve at 12 degrees, and then we get A1, A2, and 3, and P1, P2, P3. So this is very important to assess if there are, again, any calcification, any indentations, any clefts that they would be changing the outcome or the decision for the transcatheter intervention. It's important to understand all the limitations and quantification when we quantify mitral regurgitation. So we need to visualize directly the vena contracta area, and it's also important to include EROA, the effective regurgitant orifice area, and regurgitant volume from 3D in our assessment and in our protocols. Remember that when we have an eccentric jet, possibly EROA is a very important measurement, but also we need eventually to provide a qualitative and quantitative approach for our MR. But also there are semi-quantitative methods such as the vena contracta width. As you can see, it's circular in primary mitral regurgitation, is non-circular in secondary MR. And if we have multiple MR jets, don't forget that they are not additive, so you cannot add them. And practically, we know that we assess the vena contracta and the EROA from 3D reconstruction, and these are important measures when we have multiple jets or, of course, an eccentric jet. Then important is signals. They are the pulmonary venous flow systolic reversal, but many times because of atrial fibrillation or elevated filling pressures in the LV, we will see blending of the signal, so it's not definitive. But if we see systolic flow reversal, then of course indicates that we have severe mitral regurgitation. And also the density of the MR signal with continuous wave Doppler. But of course, again, in eccentric MR, it may be difficult to get a good shape of a dense mitral regurgitation. Now, when it comes to this paper from Patricio Lancelotti in 2022, he created like severe mitral regurgitation. Of course, you can see the thresholds. What we have EROA more than 40 millimeters per mercury, regurgitant volume more than 60, regurgitant fraction more than 50, which sometimes is overlapping with the MR, CMR parameters. And of course, we will have a systolic flow reversal if at all achievable, a large jet, and of course we'll have a dense continuous wave Doppler. Now, very important document is the one published almost 3-4 weeks ago at JACE about the ASC guidelines on intraprocedural imaging for transcatheter edge-to-edge repair. Remember, they mentioned about intraprocedural, so they actually describe the 9 steps during the mitral edge-to-edge repair, and they describe with a baseline evaluation because a full TE protocol should take place before they even start the transeptal puncture. So then we have transeptal puncture, then the guide delivery, the guide catheter delivery, then repair device delivery, then the positioning for the leaflet grasp, then the leaflet grasp, which is so important in the TEER, then the device performance, the final deployment, and of course the atrial shunt evaluation. So these are important steps in order to make sure that you will not forget anything from the consideration during the procedure of the mitral clip. But before the mitral clip, you can see that we do according to Hausleiter, that we have this nice table that when a valve is ideal for edge-to-edge repair, when it's complex, when it's also non-favorable, and we proceed possibly to advanced mitral valve replacements such as Tendyne or M3 now. That's why the authors of the ASC paper practically they mention ideal for TEER anatomy, or also quite more complicated that requires TMVR and or a dedicated center with surgical backup. Of course, I believe that surgical backup should always exist in TEER, and especially in patients that they are younger in age. Very important step is the supervision and guidance on transeptal puncture, and we use the posterior superior aspect of the fossa ovalis, and we take more than 4 centimeters above the mitral annulus for the generative mitral regurgitation and 3 to 4 centimeters for functional MR. So we need to keep a safe distance to avoid complications. Also, when it comes to alignment, it's very important to have the aortic valve as your guide, and practically to use the MPR and 3D, and also cut in 4 different sides in order to be able to see the clips from all angles. So if you have any, and then you use the 3D in order to guide clockwise or anti-clockwise the clip together with the interventionalist. Then, of course, an important step is how to assess the clip after the edge-to-edge repair. And this is the post-procedural assessment that we use a very abbreviated but full protocol. So practically, we have the flow assessment to see if there is any leak around the clip. Of course, the mean gradient to assess that there is no significant stenosis. And of course, we assess the ASD to see if it's significant hemodynamically and will require closure before we finish the procedure. William Zogby from Houston Methodist, he published this wonderful paper about how to assess residual mitral regurgitation after percutaneous mitral valve repair. And as you can see, we have certain thresholds that we can quantify into mild, moderate, or severe MR. However, we need to be very considerate that most of the jets are quite eccentric, and we may underestimate the jet. So careful assessment with MPR and also 3D is very important here. I would like now to introduce you a brief clinical example. 85 years old, female patient with hypertension, coronary artery disease, and known mitral regurgitation. She was hospitalized 3 months ago at the district hospital, and she has myxomatous valve. The TTE demonstrates prolapse of the P2 segment of the mitral valve in moderate to severe mitral regurgitation, and she also had flow reversal noted in pulmonary veins consistent with significant mitral regurgitation. As you can see here, she's on aspirin, metoprolol, and furosemide at the moment, and she has a BMI of 29.8. And here she has normal creatinine BNP of only 139. So after the TTE, the next step would be to do a comprehensive transesophageal echo. So as you can see here, there is significant P2 prolapse, and practically what we are doing is I'm always doing explain, and then we assess color and color compare in order to see where is the largest jet. Practically this is very eccentric jet, and here we see that there is this P2, P3 prolapse that practically gives this eccentric jet, or it's going to the anterior corner. And then the largest, of course, will be to 90 degrees, coming to 120, that you will see this prolapsing scallop. And here we isolate the jet in order to have a more comprehensive 3D vena contracta and 3D ROA. And this is the 3D that you will see that there is this posterior P2 prolapse. Then we always do the dual that will give you the atrial and ventricular component in order to exclude any indentations or any clefts, and of course to see the extent of calcification. And this is where I'm also starting to do my color. And then this is the 3D reconstruction that we do with MPR. And practically, we assessed the tricuspid regurgitation that the patient had, and it proved also, you can see here with the explain, that proved to be moderate tricuspid regurgitation. So we felt that we had a long discussion with our surgeons and our interventions on whether a patient would benefit treating the mitral or the tricuspid first. The answer is, of course, the mitral, which is more significant, severe when compared to TR, that's moderate, as I already told you. And we finally felt that it would be important to do a transcatheter approach because the patient was of high risk for surgical approach. But of course, when it comes to mitral clip or TMVR, we feel that here tricuspid, the mitral valve needs to be addressed with edge-to-edge repair. And we felt because of the anatomy and the eccentricity of the jet and the prolapsing height, practically the patient most likely would need 2 clips in position. So the decision was for mitral tricuspid edge-to-edge repair. And we're going to, when we insert the first clip, we see this significant residual mitral regurgitation. And of course, then we use a lot of MPR and 3D reconstruction to insert the second clip. And as you can see, this is the final outcome with mean gradient of 2, so there is no significant mitral stenosis. Reaching to the end of this lecture, a take-home message is important to keep the value of the heart team for optimal selection of patients. Post-procedural mitral regurgitation should be graded using an integrative approach similar to pre-procedural echo baseline assessment. And PISA evaluation has been debated, but now we have more advanced measurements such as 3D EROA, 3D vena contracta, and of course regurgitant volume, that they are more comprehensive. And don't forget this position statement, the guidelines for mitral edge-to-edge repair coming from ASC that were published 4 weeks ago. With that, I would like to thank you so much for your attention.
So maybe I think it's an excellent presentation, it's an excellent topic. It's always a question during the procedure, what is a good result? When do you say, okay, I'm happy with the result? And when do you say, okay, I need to add another device? I think that the echo is crucial in this issue. And my perspective is always count on the hemodynamics, which means if you get a systolic dominance in the pulmonic veins, I think this is a very good time to stop. But if you do not really improve the pulmonic vein flow pattern, you should aim for additional device, because in the end, the patient feels the pressure, not the color. And if you improve the hemodynamics, he will improve. But if not, he will not improve.
Yes, and I think if you I take that as a remark to mention that regarding the right heart, probably, and I would like to have your opinion about that. Sometimes we do not force the result to be perfect, because we just want to reevaluate what happens after 3 months. The patients have difficulties with the right heart. We don't know how the right ventricle will react. We don't know if the ejection fraction will be problematic. Like a staged and cautious approach for the right heart is maybe a little more important than from the left. What's your opinion about that?
Yeah, well, I mean, the tricky part is in the patients with a very low ejection fraction, because those people you're gonna need to leave some MR behind. And you just need to kind of have a little experience to know how much to give and how much to not give. I think that's a little bit, but they need, if we overcorrect that MR, they're gonna have a very difficult time coming out. But another aspect that is valuable, and I'm not sure many of us use it, is that of the wedge pressure, I should say the LA pressure from the sheath. There's no penalty to, actually it's advisable, quite frankly, to have a well-zeroed and flushed line. We use it anyhow to flush. So in order to carefully take 30 seconds to flush it and zero it correctly in the beginning of the case, so you know where you are. Unlikely anesthesia is going to give a ton of fluids during this type of case anyhow, a little bit maybe, but nothing much to affect the pressure. So if you're in doubt, let's see where you end up. And if your impression of decreasing the V waves concurs to the echo findings just discussed regarding the pulmonary vein reversal and all that, and if you improve that in both modalities, I would say, I think you feel more confident. Initially, I don't even know many people were even measuring LA pressure. I'm not sure why not. Right there, you know, it's just an extra line. We have it. The cost is zero. I think it should be routine.
Please.
Thank you. It's a great comment, which was done by George. Our experience with a functional MR is quite often lack of any systolic reversal in the pulmonic flame during the sedation. So in the vast majority of our experience with a good number of functional MRs, we don't see systolic reversal. So at the end of the day, where it is the key player in our decision-making how to proceed for a second clip is, of course, the stabilization of the first, and second, as George said, the LA pressures. It's something which is not commented. I think that it's a mistake from the guidelines. They pay all these detailed academic, let's say, interrogation of things which are useless.
Definitely adds a quantitative aspect if you take that into consideration, so it becomes more quantitative and therefore easier to make decisions.
Definitely, I agree that in functional, sometimes you do not see the reversal, you see a blunting, but you can also measure the increase of the systolic wave. It's not just yes or no. Sometimes you have a blunting, and in the end of the procedure, you get a systolic wave, which is very important. Also in functional, unfortunately, that sometimes the LA pressure is low during anesthesia and blood pressure, and it's not very, you start with a 15 or 20, and you do not really see the differences. I feel that the pulmonic vein form pattern is more sensitive than the wedge pressure, but as George says, I always measure the LA pressure before, during. It's also important in evaluating the stenosis, because sometimes you decrease the V wave, but you see an increase in the mean LA pressure, which might suggest that you created a stenosis. You should be very careful in those patients.
Thank you. The vast majority of elderly patients with primary MR have flail P2. And according to guidelines, they are ideal candidates for TEER. But currently, the guidelines do not allow us to operate them with TEER unless they are in high operation risk. Do you think that this will change in the future, since the task from these people is not to eliminate the MR because they have good ventricles, but to put it in a moderate or less grade?
So I think that the question about patients with flail that are not very high risk is still under consideration. We have 2 trials now running, the REPAIR MR and another trial focusing on elderly patients with flail severe MR, comparing TEER into surgery. And I believe that in 1 or 2 years we will be more confident to suggest for those patients TEER as first therapy.
Thank you. Just a quick comment. The primary trial and the second MV repair trial, I think, and this is, I think that both those trials are biased against surgery, and that I am willing to put my hand in the fire that both those trials are going to favor M-TEER. And the reason being, and I don't know if Dr. Grapsa has anything to say if she's still there, but or the panel's opinion. I would love the panel's opinion about this. The patient she presented, P2, 85 years old, I don't think any surgeon would go for that, even though it's a beautiful, easy surgical repair. But the woman is 85. You're not looking to prolong her life. You know, you're looking for quality of life. So you wouldn't subject her to either a mini or a sternotomy. You would not, in my opinion. So therefore, who's being randomized is patients, let's say, who are surgical candidates, and the surgeon goes, you know, let's randomize this patient because I'd like for this patient to fall into the M-TEER category because I'm a little bit queasy about operating on them for whatever reason. COPD, 77-year-old, whatever reason. And so that patient has a 50% chance of actually ending up on the surgeon's table, you know. So by that very basis, these 2 trials are kind of, in my opinion, fundamentally flawed. But anyhow, I don't know what the panel's opinion would be about that.
I just want to make a general comment about that, is that you're describing a very classic bias that exists in trials, any trial, with a device, any device, that is also available outside the trial. And the doctors, any doctors, surgeon and interventionist, well, they cherry pick who's going to go in the study and who I'm going to do the device because I am certain I'm doing a good job. But by the way, if we were certain, we would be doing the trial. But in their own mind, anyone, there are some patients that I'm not going to randomize. Well, this very selection biases the study. And whichever that means, you're in shock, cardiogenic shock, you may end up those who are dying because those who are not dying, you don't want to randomize in the trial, at another example. Or in low EF patients, bypass versus medical therapy, you're really going to randomize the patients who you think can have a bypass. Medical therapy versus PCI, we may randomize anyone because you think that anybody can have PCI. So these are different populations. So we get, unless we understand this level of bias, which exists, unfortunately, in all our studies, because our devices are also available commercially, then you have to take the results also with a grain of salt every time, and that's why you have these discussions. It's a great point. I think it's a very important point. It's not a winner takes all after any study because of this kind of a situation every study has. And we all have to address, and that's why you have this, as we say, debrief conferences, which means have another conference after the main presentation when everybody's asking you in the corridor, well, forget about the results. What are you really doing after this X and Y and Z study we just heard? And then you have a little bit more of a meaningful discussion.